Good morning, everybody. Thank you so much for joining this webinar. My name is Sati Rai. I'm Member Engagement Manager at the Northern Housing Consortium. I'm also the part of the Programme Management group for the Housing, Health and Care programme, which is the series of webinars that you're here to dial into today. Just quickly, before I go into sort of more detail about that, just a little bit of housekeeping. The session will be recorded. I hope that's okay with everyone. If there's any issues with that, please do let us know. It's recorded because we have had many people ask us to record the session because they're unable to join it, and we do this for our members right across the north anyway, so you can share the recording with others after the webinar, or it might be something that you might want to revisit in your own time. Just in terms of housekeeping, I know you'll all be aware of this, but just a quick reminder, if you wouldn't mind staying on mute whilst you hear the presentations for the first part of the session. It is meant to be a very interactive session, so we do welcome questions and engagement from yourself. And although we've got a great lineup of speakers, we also do want to hear from yourselves around your own learning experience, approaches that are working, or any of the challenges that you're experiencing. It's really around that sort of sharing that learning and how we sort of work together to move forward. As I said, this is part of the Better Homes and Healthier Lives series, which is part of the Housing and Healthcare programme that's been established across the North East North Cumbria to build on the collaborative work already underway to tackle and mobilise on housing, health and care. The programme is the region sector-led improvement initiative focused on delivering better, more integrated housing, care and support so that people can be healthy, live well and stay independent in their own home. The programme has been co-created by the North East Branch of Association of Directors of Adult Social Services, the NHS North East and North Cumbria Integrated Care Board, the Northern Housing Consortium and the Tech Services Association, with many other partners involved too. So the webinar series complements the work to date that's been done, including 2 events that we've held in Durham, bringing together housing, health and care professionals to highlight priorities, share learning and develop a programme of work. The programme to date has commissioned the Housing Lin to carry out a baseline assessment across the 3 priorities, which include warm and dry homes, older people independent living and supporting those with complex care and learning disabilities. If you haven't already seen that baseline report and sort of the 5-year plan that we've developed across those priorities, I will share the link in the chat as we go through this morning as well. So today's session, like I said, today is the second session in the webinar series. We'll be holding a session every month for the coming months. And the session today will be exploring sort of the role of social prescribers have in partnership with housing and the significant role they can play in improving lives and connecting people to non-medical services. And obviously today's focus will be that sort of housing focus. Whilst the primary role for social housing providers is to provide homes, their remit goes way beyond that than just housing. The majority of our members right across the north and wider provide housing, what we sort of term as housing plus services. And that's sort of like wider activities that are investing in their communities and people through, whether that's employability, whether that's financial well-being, health and well-being, safer communities, and so much more to improve the lives of their tenants. So there was a report that was published back in late 2022 that was carried out by HACT and the Housing Lin. And within that, they sort of referenced that the sector invested in around £750 million per year in their communities. And that's sort of around that sort of wider community investment programme of work, which what we sort of say housing plus services. So today we will hear from a number of speakers around their approaches around sort of social prescribing and what that looks like and how that's sort of been delivered, who's been involved, and obviously more importantly sort of what that meant for local people, for the communities. There will be time for questions after each speaker. So please do raise your hand or post a question in the chat and I will pick them up as we go through this morning. And as I said, at the end of the session today, we have left some space for general discussion. And again, because I really want to make the most of these sort of webinar sessions as an opportunity just to hear from others, what's going on in sort of in your organizations, in the areas that you're working in, and what can you share, and sort of having that little bit of a wider discussion so we can all sort of take something away with us today. So today's really about a bit of a call to action as part of this program of work. Like I said, there's lots of great work already being done. Some of it's about how do we scale up, how do we make it work in other areas if possible, and without reinventing the wheel. We all know that we're all under a lot of pressure at the moment. It's not getting any easier for staff, it's not getting any easier for our communities, and how can we make sure we work collaboratively together. Just to add, we will be sharing a feedback form at the end of the session, so really grateful if you would just take a minute or two to complete this. At the end of the day, we just want to make sure that our future webinars program of work remains relevant to you, and if there's anything that we can do in terms of improving that, anything more that you want to hear from, please do let us know, and we'll just very much take that on board. So without further ado, and I don't know because I haven't been able to see my screen because I've just been sort of reading off some notes, I'm going to go over to our first speakers, which I'm hoping have joined the call. South Tyneside, they launched a Healthy Homes program of work a few years ago, and from my understanding, they were sort of within the region, they were sort of first in the sort of area to do some work around sort of social prescribing and working closely with housing and health on this approach. And we've invited Hannah Jeffrey, Head of Commissioning at South Tyneside and Sunderland, and also to Dr. Philip Hodgson, who's the social scientist and lecturer at Northumbria University, who's done some sort of evaluation on that work, along today to sort of share their work and share their approach with you all. Hannah, Phil, are you on the call? Sorry, I'm just like
I am indeed. Can I start quickly sharing the presentation? Just want to check to make sure that works all right. Is that right? Can everyone see that okay?
Just coming through, Phil. Perfect. Yeah, that's brilliant.
So, should I go first?
Yeah, please. Yes,
introduction, and then we'll get going. So I think Satty's already introduced, but just to kind of repeat. So my name's Hannah Jeffrey. I'm Head of Commissioning within the South Tyneside and Sunderland Local Delivery Team within the North East North Cumbria Integrated Care Board. Phil?
Yeah, and I'm Phil Hodgson. I'm an Assistant Professor in Health Research here at Northumbria University.
Great. Phil is going to drive the slides. I'll do a little bit of a brief intro, then Phil will give an overview of the evaluation and some of the key learning we've had from the programme to date. Next slide, please. So just initially to kick us off, just to give some background to where we started back in 2022. So there was an opportunity to identify a small pot of non-recurrent money to look at how we could start to tackle some of the wider determinants of health in the system, starting to explore and think about how the physical environment that our communities are living in impacts their health, particularly around exacerbations, for example, with respiratory conditions. So that gave us an opportunity to bring colleagues together from across health. So that was within the CCG at the time, within the commissioning side, our acute trust, our public health team and housing, to start to think about what we actually wanted to do and what opportunities we could explore together. And this was probably the first time personally I'd worked with some of the housing teams, having worked in South Tyneside for a number of years. So we were also starting to build those connections and relationships across the system to enable the work to be taken forward. Through those discussions, we started to explore what had been done elsewhere in the country. There was a lot going on in places like Liverpool and Wigan, where they'd started to develop this healthy homes concept and how the physical environment impacts wider health. There'd been some work done down in North Yorkshire and Selby to start to look at social prescribing and actually taking that into people's homes and doing visits and starting to explore what kind of care and support individuals needed, which might have been more around health, but also it was also around the kind of wider holistic needs of the individual, and as well as the healthy care needs, also starting to think about the physical environment. Where we got to, we actually realised there was an opportunity to use some existing resource that we already had in the system without a need to touch any of the non-recurrent money that we'd been allocated. So within South Tyneside, we commissioned a social prescribing service called our Better You Health Coaching Team back in 2018. And we were able to quite quickly identify some resource that we could reallocate to this bit of work to allow us to kind of get off the ground quicker than we would have needed. So we were able to allocate and reprioritise where we wanted to kind of put some of that health coaching resource to support individuals in the community, taking in some of the learning from other areas, but also starting to think about how we targeted our local population and started to think about how we could utilise a population health management approach to use some of the data that we had available to us. So while we could start to think about that concept of social prescribing and taking it into people's homes, we were conscious that that resource wasn't available to do something kind of borough-wide, and actually wanted to develop and test something and use that as a learning process as we went along. So we did a little bit of work with our housing colleagues and also with some health to start to look at what data we had available. So we were looking at things like prevalence of respiratory conditions, admission rates for respiratory conditions, and starting to look at where those people lived and who was driving some of those reactive services and reactive activity in the system. We then cross-checked that with some of the housing data that the housing teams held, particularly around what was council stock, what was privately owned and so on. And through that cross-check, we identified some priority postcode areas where we wanted to start the test really in that prototype with that intervention. It actually, I think we started with 3 wards initially within the borough, which were our 3 most deprived wards as well. So the data probably didn't tell us anything that we weren't expecting, but it helped to kind of allow us to justify and explore how we started something. And as I mentioned, that population health management approach and allowing some of that data to drive that development and targeting of interventions. Whilst we'd come up with this concept of a healthy home, we were really conscious that a healthy home probably meant something different to every person. So whilst we as professionals were sat in a room talking about a healthy home, even between us, the views on what that was slightly different. So we went out to the wards that we identified just to have some conversations and do some kind of consultation and engagement. So we had some support workers who went out across the area over a period of time to start to ask some quick questions around what does a healthy home mean to you? And that provided some vital intelligence around what that meant for individuals living in those communities, and really helped to, again, guide where that intervention went in the system. Next slide, please. So where we got to as a kind of a collective, what I'm calling, I suppose, a sponsor team with our leads from the different organisations, we set ourselves and developed our aim statement ultimately, which was to deliver significant, sustainable health and housing improvements to reduce the burden on NHS secondary care by targeting housing deficiencies that cause or exacerbate preventable chronic disease and premature death. And as I mentioned, we decided we want to use data to then enable us to target our most vulnerable residents in South Tyneside. And I would just add, whilst we specifically referenced NHS secondary care, actually there was an acknowledgement that it went broader than just secondary care access into the system. It was actually it went across primary and secondary. It was touching into community services and actually also wider into I suppose our whole health and care system. Next slide, please. So the model itself, as I've briefly touched on, we looked at a model that brought together social prescribing with this new healthy homes concept. So initially, to kick us off, we started working with one GP practice, which was our deep end practice in South Tyneside, to start to look at the data in their systems. So again, looking at some of the prevalence and attendance figures to identify an initial cohort that we would target. So those individuals were identified through the practice and then proactively contacted and offered a healthy homes assessment, which would be delivered in their home. And those individuals then subsequently had a one-on-one conversation with the social prescriber from our organisation called First Contact Clinical, and essentially, I suppose, a household care and support plan was developed to identify what would help that individual, both in terms of the physical environment within their home, but also from a wider kind of holistic approach around the health and well-being of that individual. So the model commenced in 2023, I think it was September 2023. And alongside that, we also commissioned some evaluation support from Phil and colleagues at Northumbria University to ensure that we were really understanding whether the model was working, but also any kind of learning that we took from that initial prototype back in 23. Alongside delivery of the Healthy Homes approach, we also decided we wanted to look at what training was available to everybody across the system. So whilst the Healthy Homes approach was being tested in three wards initially, we wanted to look at how we could also skill the workforce up across the whole system at the same time. So we commissioned Making Every Contact Count training programme, which was specific around some of the housing pressures in the system and starting to touch on some of the learning that we were taking from the programme, and also providing that knowledge and skill to our workforce across health and care. So that was offered to everybody. What I would just add, so that whilst we kicked off with a GP practice, we have continued to build since then and started to work with a whole range of teams across the system, directly working with our housing colleagues as to how that team can enable referrals into the programme, but also working with some of our acute trust services, for example, our A&E department, where they might have frequent attenders, where housing might be causing some of those exacerbations. So as I mentioned, we commissioned an external evaluation, which we got, I think it was March last year, and we got the final version of that. And I'll pass over to Phil, who'll give you some of the highlights in the learning to date.
Well, cheers, Hannah. So yeah, I'm Phil Hodgson from Northumbria University, and I'm just going to talk everyone through a brief kind of summary of the findings from the evaluation on behalf of my colleagues, Dr. Alex Curtin and Nat Foster, who are also in the team. So usually when I kind of start a presentation on this topic, I'll have a few sort of slides about the importance of housing or home as a social determinant of health and well-being, which I think is pretty much preaching to the choir today, but just to kind of flag up from a research perspective, although we have a ton of this evidence, and there's a load of information here on the slides that relate to it about how it impacts education, attainment, health, all these general things. One of the tricky things that we have as evaluators is a lot of the research tends to focus in on a more sort of housing lens, just the sort of bricks and mortar of people's house. Whereas what was interesting about this as an area to study in was it was a much more sort of home focus, much more holistically how people experience those environments, and maybe looked at broader factors as well, which made it really kind of interesting. And just also to say from a general kind of perspective as well, in terms of what the research looks like around home and health, although we have this weight of evidence, we still have, what's kind of perceived at the moment as a housing crisis. We still have a huge range of challenges in a sector which is primarily driven by kind of market factors and kind of somewhat outdated models alongside the lines of kind of people's current buying and living habits and things like that. So there's a real tension, which thankfully I think is starting to get more attention now, but certainly is something which in itself has kind of reached a crisis point before we've come to this stage. But as I say, I'm sure most people are familiar with those sorts of issues. Also, not to repeat what Hannah said, just a little bit about the service from our perspective, from an evaluation one, just to add into some of the context. I think what we thought was really interesting from a research perspective as well, when we've carried out evaluations of similar services in the past, they've tended to just be like local authority tenants or through housing associations. What was really interesting about this from our perspective was, yes, that it was targeted at the deprived wards, but also that it was kind of across different tenures. So we have not just housing association or local authority tenants here, we also had private homeowners, we had people in the rental sector, and also the focus on the eligibility criteria as being across anyone of low household income, having a long-term health condition, having somebody in the household who was over 65 or under 5, or pregnant, made it kind of very broad and kind of rich sample for us. So what we did was we took a mixed methods evaluation approach. So from a quantitative perspective, we looked at the existing service data with an eye on creating a data capture tool to look at the financial benefits. We also spoke to through qualitative interviews with households to get the service user experience, all hopefully with an idea of feeding into a larger scale evaluation moving forward. So very quickly, because I can talk about these at length, so I'll try and kind of run through them a bit quickly. I'll just go through the summary headlines of each data set. So the first thing from a quantitative perspective, we looked at data for 48 households between May and November in 2023. And the first thing we found, as I'm sure you would all expect, was the complexity of the household. So the majority of them weren't eligible on one criteria, they were eligible on multiple. So and 58% of the sample were eligible across 3 of the criteria. And again, you would expect that older people were more likely to have low household income and have an ongoing condition and vice versa. So that complexity that we sort of expected to see was in evidence in the data. There was a lot of concern from the quantitative perspective about the housing conditions. So 48% of households were concerned about fuel poverty, 58% had difficulty heating their own home, 31% at risk based on a housing need, and 43% experiencing at least one sign of condensation. So multiple sources of evidence on a poor standard of housing overall. And alongside that, from that holistic home-based approach, they highlighted a range of other needs related to where they lived. So things like asking for financial advice, social isolation, antisocial behaviour came up as well. So it wasn't just poor housing that they were concerned about. There was a range of related factors that the service was able to address and identify. So what we did was, and I sort of have to heavily caveat this a little bit, so we didn't carry out a full health economics evaluation on this. The data itself didn't support that, as well as the kind of timing of what we did. But what we were able to do was to map each of the category 1 hazards identified in the home consultation against a potential cost saving to the NHS through the BRE cost of poor housing report. And as you'll see from this table, there was a lot of evidence of excess cold, dampness and falls primarily coming through in that. So even though we're only talking around 48 households and we're talking about a limited data period, what we actually found using this model was potential cost savings to the NHS of around 71,000. So again, that's something that we're thinking about a larger scale evaluation, adding some rigour to, because I think you can see the potential really strong impacts from a health economics perspective of addressing some of these home-based concerns. So I'll just quickly now move on to the qualitative data. So alongside the data that we looked at from the service, we also interviewed 18 participants across 15 households, and I'll quickly try and give a summary of the kind of 5 key themes that came through from that. But I'm conscious of time, so I won't spend too long on them. So the first one is the notion of person housing fit, and what we found quite a lot of evidence, as you would expect to, people with health conditions that were being exacerbated by the home condition that they lived in. So from the first impact, that happened on a physical level. We had people, with COPD struggling with dampness and cold. The example given here is somebody with visual difficulties who had very dangerous kind of steps in their homes. And what they were saying was, because it was their home for a variety of reasons, a lot of people couldn't afford to move or didn't want to move. They were sort of trapped in this environment that was potentially exacerbating this existing health condition. What they also said, which I think was interesting as well, was about the mental health impact that this had. So where people had pre-existing mental health concerns, they were, again, finding those exacerbated by their house. So some people who would potentially have anxiety talked about being worried about their fuel bills or worried about how to get their clothes dry. And as a result, they would kind of, block their doors open in winter to get a through draft to try and address them. So really kind of potentially difficult behaviours there. But then also people talked about the stress and worry that occurred from having a healthy home, being worried about getting up and down the stairs, and that adding to the concerns that they had, been worried about their fuel bills, and also in a lot of cases being embarrassed about having friends or neighbours or visitors into their house because they were embarrassed by the state of it as well. So while that related a lot to people's individual homes and their own physical environments, we also found a lot of more sort of place-based concerns with it. A lot of people concerned about antisocial behaviour, a lot of people concerned about their relationship with their neighbours, and again, those having a negative impact on them. So, it's not the location, I just couldn't stand the people. It was a recurring theme that went through there as well. And what was interesting from a kind of specific location perspective on this as well, a lot of these people had lived in this area for a very long time. Some of them were still in family homes from where they were a child, or maybe 1 or 2 streets away. And while in a lot of cases that had a positive impact on their kind of existing resources and social networks, in others it was a detrimental factor because they had a very strong perception of decline in the area. They were worried about seeing fly tipping and graffiti and things not being as nice as they perceived them to used to be, so therefore more challenging to them as well. In terms of the actual experience of the service itself, we used to call this theme service experience, but what we end up talking about primarily is loveliness, because what they defined was they thought the service itself was lovely. It was a lovely visit from somebody. It was a lovely person coming to see them, even though it was actually the person's job, this is kind of real from here. This idea of having somebody come to your home to see how you're living, to actually engage with you on a one-to-one basis was something they really valued in themselves, and they would talk regularly about how it was just lovely to have that experience. And one of the things that's interesting about that from an evaluation perspective is if it's really important to people, it's recurring throughout the data. we don't have many metrics to measure loveliness. It's not really a formal thing that we can kind of recreate. So we try to unpick a lot of what that was. And a lot of people would then go on to talk about how it was not only the facilitation and the kind of the interaction they had with the person themselves, they really appreciated the fact that it was in their own home. They valued that somebody took the time to come and see them, to see how they lived, how they managed, how that related to all these factors. So having a lovely person, but also that lovely person take the time to come and see them, was really important to them. And the fact then that they felt like they had a link to this person, they felt like they had a named person that they could ring up and seek out ongoing advice, that it wasn't a sort of faceless service, that it was somebody that they really sort of valued the person of, meant that they felt like they would be able to opt into it more often, maybe return to it and seek ongoing advice moving forward. In terms of what the actual impacts then look for us, so obviously there were physical and psychological impacts, and so the changes made were valued by people, kind of gave them those reassurance and hopefully more healthy behaviours. Just to flag up, some of those were really small changes having big impact. So the one that I always kind of draw out from this is we had one person with anxiety who was really, really concerned about their energy bills and had a light fitting with non-energy efficient light bulbs and multiple bulbs, and she was terrified of turning it on. Every time she would turn it on, she was worried about the bill. So even the ability to change a light fitting or to change a bulb reassured her, made her more likely to turn her light on. So something as small as that had a positive impact alongside larger things like, stair lifts and other home adaptations. When we asked people what they would do without the service, and how they all said they would have left any changes to their house to a crisis point, they would wait until a fall. This person here saying, I would have waited until I dropped down dead. People didn't think about their home as a healthy preventative environment. They would wait until a crisis point. So therefore, it was really important that the service contacted them and addressed those issues before it reached that, as obviously that would lead to a very kind of significant outcomes from it. And again, they also really talked about the personalization, the fact that they saw valued by it was an outcome in itself, was feeling like they were kind of seen, heard in a way that they maybe weren't from other services as a result of the nature of the intervention, but also the fact that it took place in their homes. And then just a couple of final things to flag up. So the next one were areas of barriers and accessibility that we found. So people talk about there was a low level of awareness of the service, and they were kind of flagging up other people that they felt should, if they were aware of it, would be able to opt into it more often. And they felt like a service like this needed to be more clearly communicated and disseminated, because of that issue of prevention, that people didn't think about it until it reached a crisis point. I think tenure was also really important. So we had a small cohort in our sample who, as I said earlier, were private renters or homeowners, and they all talked about the fact that they didn't think themselves eligible for a service like this. They would feel like they had to fix it themselves because it was their responsibility, and therefore if they didn't have the resources to do that, it was just an accepted thing that they were going to live in an unhealthy environment. And also age is important. So older people talked about the importance that they felt that like the service had come to them because they didn't want to be seen as acting for a handout. People talked about they'd paid their taxes. They didn't want to be seen as a kind of a scrounger in that sort of way. Even though they were perfectly entitled to it, they wouldn't opt into it. So kind of two areas of development in terms of that population. And then just finally, quickly, when in terms of thinking about what the future direction of the service would be, they thought it was really important that it became a source of ongoing support for them as they move forward. And the issue of awareness raising, they talked a lot about fairness, that they thought that it was good that the service was targeted at the people who really needed it, and that should be a point of emphasis going forward. But the one thing I want to kind of flag up with people just before I finish is one of my favourite quotes from this evaluation, kind of all of the others. So we would ask people, when we asked them what the impacts had been, thinking it was going to be, more ability to get upstairs and stuff like that, the partner of one of the residents said that what the service had given him was hope, was that before that he'd had no hope. This was a gentleman who was living downstairs in his house, couldn't get upstairs at all. And he talked about how all he wanted to do at the end of the day was to go upstairs and sleep in his own bed with his wife, and he couldn't do that because of it, and he felt kind of hopeless and sort of trapped in this bubble. And what he said that the service had given him, because he felt valued, because because he felt heard and because he felt seen about it, as well as the advice that was given, was that in itself was an outcome, and as a result there was kind of hope. And I think that's a really kind of strong metric when we're trying to look at kind of outcomes and evaluation perspectives, how important that service was to that individual. And just very quickly then to summarize at the end, we've got a number of kind of recommendations to make in terms of those ongoing support and awareness raising, the importance of the data as well, feeding into what we can do from an evaluation perspective. If kind of further and more rigorous data is collected, what we can give then to enhance that health economics element of it. The targeting of the key groups, I think the wide range of outcomes that you can see, not just physical health, but psychological health and those kind of broader issues in relation to issues like hope. But I think the takeaway that I have from it is, you know, people's relationship with their homes are complex, and the relationship between their home and their health is complex as well. And that is often quite challenging from an evaluation perspective and a service perspective. But in this case, people really valued that person, that lovely person who came into their household. They felt seen and valued and heard from it, as well as getting the outcomes associated with it. So there was an enhanced benefit through the model of delivery, and this idea that, you know, they felt like they had somebody, that the council or a service provider or whoever it was seeing them, was seeing their concern. You know, generally speaking, people like people, and there's an enhanced benefit to having this sort of intervention in comparison to, as you can all imagine, information on a website or a flyer or something like that. They really valued that impact as well. So that's the key finds. If anyone has any question, my email address is there, but I'll just hand back to Hannah to finish up.
Thanks, Phil. So really, just to give you a quick idea of what next for the Healthy Homes programme within South Tyneside. So after that initial evaluation, we regrouped as a kind of a collective team with our exec board leads from across the organisations to start to think about where do we go next as a system in relation to housing and health. And we set ourselves a number of kind of goals, I suppose, around the short, medium and long term, taking us right into kind of 2027 and beyond. So in that immediate short terms, a lot of this is kind of underway, has already happened really. So start to take that evaluation and the recommendations Phil's just ran through and start to embed them into our model moving forward. We have scaled up the pilot, so after that initial test with one social prescriber, we've doubled the capacity to 2 social prescribers to support the bit of work now, and have extended it to other areas within the system, again using data to support where we would target next and building on those postcode areas and wards, and really starting to up the engagement with key teams across the system to make sure we've got that knowledge growing, and people know what the service is, what it can do, and starting to access that for people they come into contact with on a daily basis. MEC training, as I've already touched on earlier, really starting to push that across the system and encourage an uptake of that. We've had that highlighted recently at our Health and Wellbeing Board, and asked our Health and Wellbeing Board members to start to ensure their teams are engaging with that offer. Phil's already touched on this. We'll continue to explore options around further research and really starting to think about how we can get underneath some of that the health economics data a bit in a bit more detail. We've also set up a local community of practice and had our first event in November last year, and starting to look at how we start to build those relationships and connections across partners to enable some of that multidisciplinary network and just to happen as a kind of business as usual within the system, instead of requiring kind of standalone events or services in place, to really support, I suppose, support the system to move that forward as well. In the medium term, there's a lot going on around embedding regulation and legislation off the back of national changes, and also connecting that into local changes. So South Tyneside Home has recently moved back under the council, so that happened towards the end of last year. So that gives us real opportunities to further embed some of this approach across those teams. There's a number of bits of work that we're going to look to undertake, from private stock surveys to understand how we can I suppose, engage some of those owners of that stock and how we can support those individuals going forward. As Phil mentioned, it was tenure blind. We haven't just targeted council housing, it goes much wider than that. We want to do some further work on learning around how social housing providers and privately owned and privately rented properties can start to learn from what we've done so far, and also engage in some of the bigger work, for example, the community of practice going forward, and continue to explore how we can scale up and embed a sustainable model that's available across the whole system. So that's kind of next on our list, to look at that sustainable funding to enable us to embed it as a kind of a standalone service for the system for the long term. And I think that's it. So happy to take any questions. We do also have Amber on the call now, who's our one of our lead social prescribers in the service as well. So if there are any specific questions on the delivery of the service on a day-to-day basis, I'm sure Amber can help with those questions as well.
Thank you so much, Hannah and Phil. Really, really interesting piece of work, and obviously is reaping its benefits. And obviously, you know, really good to see sort of that sort of forward plan in terms of next steps. Before I open it up to the floor, there's a few questions and comments in the chat that I just want to pick up on first. So, firstly, there's a Robin has asked if you're able to share the Healthy Homes assessment. So if that's something that you're able to share wider, so others can maybe look at it and maybe use it within their own organisations, is that something you're able to do?
Yeah, that's we'll get in contact with, well, Amber will be on the call, so it's certainly something we can look to share. It obviously has been personalised to South Tyneside and what's on offer in South Tyneside, so it may just need personalised to other areas. Amber, I don't know if that was you coming up right there.
Yeah, I do have a copy of the checklist. Like Hannah said, there is some parts in there that are personalised to the services that we have in South Tyneside, so I'll quickly take those out and I'll leave the questions that we cover on the different topics to do with housing and living, and then I'll share that just in the chat so that people can have a look at what we'll cover.
Brilliant, thank you so much. And then Ella's asking, were children and young people included in the feedback, interviews or evaluation to understand what the impact of the they experienced from the pilot?
Yeah, so I think of the 15, I think 2 households had children in them, so they weren't included in the actual interviews themselves, but the households themselves were included within it. But I think we skewed more to the older grounds due to the first wave of the clients that we had. And yeah, so one of the things that I think came up quite a lot about that was less about the kind of the state of the home, more of those place-based issues. So we had quite a lot of discussion in those issues about antisocial behaviour and kind of worrying about broader environmental factors that came through it, alongside the kind of, you know, the impact that it was having on the people in the household themselves. I don't think in the very small numbers that we're looking at in terms of that feedback, I don't think we had a household included in the evaluation where there was a health concern related directly to the children in the household, and that would definitely be a limitation. But as I say, that kind of first wave that we looked at was focused more around COPD kind of registers and things like that picked up, so skewed a little bit older in that sort of way, but there was certainly some discussion of it where it was there.
Sorry, they're all coming through thick and fast now, which is absolutely brilliant. So Dawn's asking what connections were made with sort of the voluntary sector, obviously around unclaimed benefits, addressing social isolation, because obviously there are so many resources available out there across.
Yeah, so the initial work, so before we actually kicked off, we did establish a bit of a kind of steering group, and that had representatives from our VCS sector on that, as well as colleagues from the local authorities, so leads on things like Eco4+. We had Green Doctor there, for example. So there was a whole range of organisations involved from the outset, really. So whilst we had an exec group leading some of the work, we also had a steering group which was made up of partners from across the system. I suppose the ethos is social prescribing, and they have those connections into the wider voluntary sector organisations, things around supporting people to get unclaimed benefits, social isolation and so on. So I think there's 2 aspects. They actually were part of the development and kind of mobilisation of the initial bit of work. Our social prescribing provider is a VCS organisation, and then they've also got a role within the system to then connect people into what's out there.
And obviously you mentioned the MEC training. Can this be shared, or is it only for the workforce in South Tyneside? It is a wider programme, isn't it, the MEC? So
the MEC, we specifically commissioned a bespoke training for South Tyneside, which was to look at fuel poverty. I'll have to double check where we're at, because it is an online system, but I will double check because I'm not sure whether we will be able to share it, but I'll confirm. Yeah, no, I think from my understanding, because we've had some conversations around sort of MEC, it is a wider programme. So what I'll do is, after I've taken these sort of questions before the next speaker, I'll add the MEC link in, and there's a key contact there, because I know some of the local authorities are able to get some free training as well, and I think that could be open outside, obviously wider as well. So again, we'll obviously share anything that you can, if possible, Hannah, or if there's any other information you can shed on it. But my understanding is that there is actually it's a wider generic programme that can be tailored to
sort of organisations, because it's something that we're definitely looking at through the Housing, Health and Care programme. So I think it is that making every contact count, isn't it? We just need to sort of roll that out. There's and obviously the MEC team are really, really keen to sort of roll this out wider as well.
Yeah, and I suppose just to add, so in the MEC training that we've done specifically for this bit of work, we have referenced the Healthy Homes project as well, because it's been a way for us to increase awareness of that programme across the system. So it gives kind of that support in understanding that MEC approach when people are in contact with individuals, but also it allows them to know they can signpost into the Healthy Homes team for a more in-depth assessment if individuals require it.
Yes, so Louise has actually shared the link there, and Craig Robson was the contact that was coming to me in my head as well. So yes, if thank you very much for that, Louisa. That's the contact there around sort of MEC. It is a sort of a regional programme, and the regional leader is Craig Robson. So you can just drop an email to Craig as well, anybody that's interested in that as well. So just going down my list, sorry. Given the focus on respiratory conditions, was support provided around stopping smoking for those who smoke, or any awareness raising around secondhand smoke in the home as part of that programme of work?
I don't know if shall I answer this one?
Yeah.
So due to the work we do, I think you'll see on the checklist that I provided, part of the questions we asked towards the end was what else is going on with this person's health and well-being. So was that the smoking? Did they need to change kind of how they were caring for the home, the diet, all of these other things that have an impact on people's health. So we weren't delivering smoking cessation to these people, but we could do the behavioural change side of things if needed, and then we would support them to engage with smoking cessation services, like in South Tyneside, it's mainly like GPs, pharmacies, things like that. So it wasn't necessarily that we were providing that smoking cessation, but we definitely were touching on what behavioural changes this person could make to better improve their health.
Thank you so much, Amber, and thanks for sharing the checklist as well. Diane's asking, would be interested to understand how much of the interventions were for social prescribing approaches activities and how much was for other tangible elements, thinking around fuel poverty, where obviously they do a lot of work across housing associations on sort of fuel poverty as well. So I suppose it's just about what was sort of social prescribing and where did it come in other places?
I think most people who were supported through the Healthy Home Scheme also valued some social prescribing support as well, but we made sure not to blur the line of like I wasn't the person who was delivering that fuel poverty kind of not the fuel poverty, but like say a person needed energy efficiency advice, I would make sure that there was the right support in place from the energy efficiency services. Say it was around benefits, I would make sure that a benefit advisor was involved as well, and then I would do just the focus on the social prescribing, so the behaviours and the lifestyle. So it was very blended, but I would always make sure the right people were involved in the right things.
Okay, and then I'm going to quickly go down. So the around emergency services, specific services, were they brought in sort of obviously fire brigade around sort of fire risks and hoarding and all of that? And I think, again, that's a sort of a social prescribing thing, isn't it, really?
Yeah, so it works quite closely with the, I can't remember what they're called, the Tyneside Fire and Rescue Service, and they have community fire officers that go into people's home and do fire safety checks. So as part of the checklist again, which you'll see, there is a section to have a couple prompts what we can look at, like fire safety in the home. So if they're using any creams that are a fire risk, smoking, gas heaters, electric heaters, things like that. If we noticed 3 or more of them, we would ask someone from the fire service to go out and do a fire safety check in the home.
Okay, and then Dawn's saying there, obviously, I do worry around the level of resource that's going into social prescribing. How do we link all these up? And I think that's what obviously webinars like today are about, you know, we know that social prescribing network is brilliant. It's so vast. And again, it's that, you know, sometimes you ask yourself, what exactly is social prescribing? And as you've just sort of said, it's about how you don't blur the lines, because there's other things that other providers are able to do. And how do we make sure that everybody is involved and we're not just duplicating anything? So any ideas around that in terms of how we link all these up?
So I would say within South Tyneside, we've done a lot over probably the past 6 to 8 years around establishing things like social prescribing networks and connections. And while some of it kind of dropped off during COVID, it's a bit of work that we're restarting now to understand what the wider social prescribing strategy and plan is for the system. And that is with all partners around the table. Social prescribing is talked about, I think, in a lot of places at the moment. And we're aware, for example, of the PCNs, we've got social prescribing workers, we've got commission services, we've got VCS partners funded through things like Big Lottery. So we are trying to ensure that the relationships are there and drawing some of that together to make sure people are aware of what is going on in the system through that. So just trying to maintain those connections and building the trust, I think, across different providers of services as well as being quite key.
Brilliant. And then I can see that there's lots of resources that have been shared. So thank you so much, everybody, for sharing all the resources. We'll try and populate all of those onto sort of one document and we'll upload them to the Boost platform, where you'll be able to access all the recordings and the presentations and everything as well. And I don't know, again, Hannah, Phil, whether any of you or Amber wants to just add in your contact details if there's any other questions that anybody else wants to ask you outside of this. I'm sure you'll probably get, and I do apologise if your inbox gets spammed, but I'm sure there'll be a lot of questions, because I think obviously the initiative that you've ran there and the work that you've done is something that a lot of organisations and a lot of sort of areas are sort of looking at, because it works really, really well. And but thank you so much for sharing your approach this morning. And I think just following on from what we've just heard and some of the questions that have come up through the chats, which again, thank you so much, everybody, for all of your engagement and for all those questions. Please do keep them coming. I think that's what it's all about. And obviously, if anybody else wants to just raise their hand and come in about anything that you might be doing in your area that might be either a little bit different or has worked really, really well, please do share that as well. It'd be really good to hear from you as well. But I'm going to move on to the next item on the agenda, which I think really, really follows on really nicely, actually. We've got Andy Coulthard, who's a Community Regeneration Manager at Living, which is a housing association across Durham, and Susan Garrett, who's a Health and Wellbeing Coordinator at Durham Community Action, who, what I would say, this is a bit of a quick win and done really, really quickly. And that's something I've been sort of involved in with conversations through Andy around some of the work that they've done across Durham around linking up their social prescriber network into housing and vice versa. And again, just by bringing members together in a room a few months back, like late last year, how that's really started to move forward quite rapidly, really, and really, really start to get on everybody's radar. And I think, it was mentioned in the previous slides around some of the findings around just that awareness, not knowing that these services exist and that they're out there, or these schemes exist. So I think that there's a big point for all of us to take out a way around that sort of comms and awareness piece as well. So over to you, Andy and Sue.
Thanks, Zadie. I'll just try and share the screen. Just tell me if we've got something coming up. Bear with me a tick. Does that come up?
Yes.
Yeah.
Brilliant. Is it in presentation mode? Just asking there.
Not yet. No, if you just put it in full screen mode.
Bear with me a tick. Can't see the bottom of it at this moment in time, so I will just nip upstairs up the top. Bear with me a second. Has it come up there?
Not yet, Andy.
Sorry, guys. Bear with me a second.
Just click. Oh, we got a slideshow.
Yeah, I can't click down for some strange reason. It won't let me go down below the screen to get the slideshow bit.
Andy, if you go over to the top left-hand corner and click on the little sort of like screen thing there, that should show. Go a bit further.
You want to cross this one here? Oh, sorry.
Do you want me to share mine?
Try yours, Susan. Yes, apologies.
Yeah,
if you can't go for that one, and then we'll jump in.
Yeah.
Sorry, guys. Apologies for this.
Well, you need
All right.
to stop. If you can stop sharing, then I can kind of like do what I can
Will
do. Okay.
Coming up.
Thanks.
Thanks, Susan.
No problem. Right. Sorry about this.
All right, don't worry about it. Joys of technology.
It's not even letting me do it now.
Oh, isn't it?
Wait a minute. Let's see if I can move this over here. What's that like, folks?
That's great.
Yes, brilliant.
Nice one, Susan. Thank you. Sorry about that, guys.
Fine.
Do you want me to just set
Okay,
some
then.
context, Susan, and then we'll jump in, then you jump in?
Yeah,
Is that okay?
sure, no problem at all. Okay, then. So, this is a grand photo here of Andy and myself and the others. And Saki's just mentioned there that between Andy and myself, so that was Living in Durham Community Action, we had an event last year where we brought all social prescribers across County Durham and also housing providers across County Durham together in one big room. And we'll talk about that a little bit later. So Durham Community Action, who I am the health and wellbeing worker for, we support the social prescribing link worker network in County Durham. And sort of like the work that we do is very much supporting the voluntary and community sector as we're a local infrastructure organisation. My role includes the support of the social prescribing link worker. We don't employ the link workers. We are there just to support them because of the work in which they do within the voluntary sector, and we recognise that sort of like they are very much part of that voluntary sector work. Andy.
Thank you very much, Susan. Yes, Living Housing is situated in probably about the south of County Durham. We have around about 9,000 homes, and we kind of have, where I work, basically it's within health and housing. It's within housing and communities, and sustainable communities is one of the key things that we've got, and an offset of that within our particular action plan, or our plan A, is around health and wellbeing. We're also quite an active member of basically the Northern Housing Consortium, which links into what Saki was talking about earlier on about all the different working groups around health and housing. But what we also do is also part of our own county's health and housing group going forward. So we've got a variety of different levels coming in, basically feeding into this piece of work. Thanks, Susan.
So social prescribers in County Durham are quite different to across the northeast. As I said before, social prescribers are employed either by their local GP practice on behalf of the PCN or through a federation. Some of them do sort of like have a base within the GP practice. Some of them work from home or from other settings. There's around 56 social prescribers across County Durham, all working, as I said before, different organisations, different sort of like GP practices. The work that they carry out is very non-clinical, so they don't write prescriptions, they don't do sort of like the medication. And I'm probably sort of like sharing this with a lot of people who already know what social prescribing is, but just to sort of like do a bit of a review kind of thing. The role is very much about connecting people within their communities, finding out what's happening within their communities so they can better support people. And for example, debt management might be something that somebody comes to the GP about. That would be the role of the social prescriber to support that person, because you know that person is presenting possibly with anxiety, mental health issues. And at the bottom of it, there could be some social element, which could include the house in which they live in. So this is very much around those social prescribers linking up with what's happening with their community to better support the person who they are working with. And there's other bits of work that they do, which is very much focused on the GP practice in which they're working for, or the PCN. So the partnership between housing and social prescribers was really kind of like brought to a kind of head last year, I think, really. And what was happening was social prescribers were very much telling us about the issues that they had, contacting housing providers. Who should they be contacting? You know, and it's quite difficult, I suppose, when there's also a number of housing providers across County Durham as well, to make sure that you're connecting with the right person. So what Andy and I actually just came across this kind of, as we were talking about something else, and I just said to him, can we not get housing providers in a room together where social prescribers can find out what other support that housing providers provide, and also those housing providers as well find out what social prescribing is about and how they can also refer and acknowledge the work that each are doing. So this was why we had this event in October, November time last year. And I have to say, it was noisy, it was buzzing, and a lot of people got quite a bit out of it. I would also say that there was connections made. Social prescribers went on to do presentations with individual teams from those housing providers as well. And what we're going to be doing is, this is going to be a regular thing where we're hoping that we can get those social prescribers and housing providers together just to review the work. And we have an event coming up in June, which will also look at homelessness as well. Andy, do you want to pick up there?
Yeah, thanks very much. I mean, again, just to set some context as well for you guys, is that this is pretty early doors for us. As Susan kind of mentioned, we only started this in kind of October, really practically kicked into this in December time. And it was kind of where South Tyneside and kind of Hannah and Phil's kind of giving you an overview. They've been doing it for a number of years, so it's kind of a starting point for us. But it's about not reinventing the wheel, which is key to us. Susan, can you jump us onto the next particular bit? Is that all right? Thank you very much. Again, preaching to the converted, basically, we know from a housing perspective that we have got to sustain our tenancies. That's part and parcel of our particular business. But what we need to be is more efficient. And for us as Living, we are quite a small kind of housing association group with about 9,000 homes. We have our internal services that already work for us, which is kind of like the financial well-being side of things, which people have alluded to, as well as kind of like the employability side. But from a health side, what we don't do is we can't do it internally. We haven't got the specialisms basically in there. And this is like working, for example, alongside SATI and groups within the county, where we go out and we work a lot and collaborate with our particular partners. We need those trusted partners to be on board to be able to provide those one-to-one services that we have with people, because we know that we have vulnerability. And more vulnerability as we go along. We've had those particular things that kind of Hannah referred to and Philip referred to about the cost of living and COVID. Our particular tenants are struggling in various different particular ways. And we need to find something that we can basically work with and provide with basically that support to those individuals that really, really need it. And this is kind of where we start to kind of do that collaborative approach. Susan, do you want to knock us onto the next particular slide, please? So this is where our partnership approach comes into it. This is something that we're good at, as we said, because we're a smaller housing association. We try and bring those relevant partners. Susan's from Durham Community Action, as mentioned. We've got a really good link with that. That's the voluntary third sector, basically, those organisations we can do. But DCA is so much more, basically, as Susan's mentioned. They have that networking ability to be able to bring partners together. And from a social prescription perspective, when we started looking into this, which was quite interesting at the time, because we were talking about this from the health and housing perspective, while Susan and her colleagues from a social prescription perspective were talking about this at a particular level with regards to kind of how do we work more with housing, because we've got a lot of individuals that this will benefit. And that kind of knowledge, that awareness of each other basically brought us together and around that particular table that we talked about. The event that we had in November time, which is mentioned further down there, wasn't just about living housing, it was about housing association colleagues around the county coming together to work with social prescribers, to have a conversation alongside our colleagues from our county council at Durham, who oversee what we call Durham Key Options, which is our overall letting process for all the housing associations. It was about that collaboration around that table and that understanding, which was our starting point, because social prescribers were saying to us, we've got lots of housing people that we work with, social housing people. How do we kind of come forward to have a chat with our colleagues in social housing around things like damp and mold, which you've mentioned, around things around letting? How do we provide that information? Because a lot of our people are suffering, be it from a mental health perspective or whatever other particular ailment, through these particular areas where they're not sure about and how we can help. So that first point of contact for us, sitting around that table, having that conversation was like a light bulb moment, basically, for people. Oh, that's how you do this. That's how we can work that together going forward. And I think, as Susan said, that establishment of that regular conversation going on is the most important part. Susan, do you want to put us on to the next slide? So how this works in practice from a living perspective, I know I've mentioned that we have other RPs and housing associations that are part and parcel of that. For us, we've got a digital mechanism where we can record everything around our tenancies, basically. We have tenancy visits on a regular basis where our housing advisors go out, have a conversation with our particular tenants and their families, and find out where they are at a particular their journey. What do they need? What do they require for them to sustain their tenancies? Now, we said we can actually do the work around financial well-being. We can do the work around employability. But the gap for us was always around the health side of things. So we set something up within our particular system that we can identify if those individuals require some help. It's very quick to go into the system. All we basically need is a name, a contact, what the concern is, and have their permission. And we can pass that on to our leads on the social prescribing perspective around the county. They will then kind of triage on what the requirements are. And we've got something, apologies, Susan, I can't remember if you've mentioned this, but we've got something like 40 or 50 social prescribers around the county. And depending upon where the geography is, those individuals can then come in and support those. So that one-to-one, as we've talked about, and Hannah and Philip's already mentioned about that hand-holding, that support, that kind of signposting has been key, and we can bring those individuals in and work them alongside our tenants. I mentioned this as kind of early doors. We've only just started this in December, and that notes there that 20 tenants have been referred into the system. That's now up near 30, basically, where we sit in February time. And generally, just to give you an overview in regard to kind of how that's worked for us, it's been very much about kind of social prescribers meeting up, having a conversation, looking at what their particular needs are. And I'll give you an example of an individual, for example, whereby they have supported them into volunteering. They've supported them into kind of being involved in sitting on the living community insight board, which is where we have our tenants and we get the voice of the tenants going forward. So they've supported them by coming along and helping them attend that as well. But they've also linked in and being able to look at what the financial issues and work alongside our side of things. So there's a mixture of all sorts of different particular parameters here for that individual. And that's the wider kind of wide support package that we can provide. Our next steps, and this is going to be an interesting one because Andrew's on next from HACT side of things, is kind of how we explore and we measure that. Philip's mentioned how they've done it from an academic perspective. We want to see how we can look at this going from a journey perspective. So what's the journey been for our tenant, basically, with working with the social prescriber? So we have a HACT model that we use around social kind of value. Now, can we kind of play with that? And I'm sure Andrew might pick this up in his next particular conversation. But that's at this moment in time where we're talking with Susan and colleagues and how we develop that going forward so we can show the progress that's being made. Susan, I shall pause there. I'll put us on to the next slide.
Yeah. So there's our contacts. More than happy for people to get in touch with us. And I'm sure the slides will be shared anyway. I'll just stop sharing my screen. I think that should work now.
Thank you, Susan and Andy.
Yeah.
Really, really useful. I think just to add to that, because obviously I've been speaking to you quite a bit, both of you, haven't I, really around how this has sort of developed, and obviously we've had really, really positive sort of feedback from obviously all the other housing providers as well. And I know somebody's put in, does the other social housing providers also provide this service, or is just living? I don't know whether you've heard anything back, Andy, from any of the others that were in the room and how they've sort of moved forward.
There's a few come back to us, basically. We're the only ones that's got this particular kind of digital referral mechanism because we've already got that in the system and are able to kind of do that. Some of our other particular kind of housing association colleagues haven't. So they're building that relationship. They're actually going out, having a conversation with their relevant, I suppose, social prescribers to see how they can develop that relationship going forward and it might just be a contact rather than a digital contact. So we've got colleagues from Believe, Carbon, Benicia, who have also been part of this ongoing conversation. We've also got colleagues from Durham County Council who have also started those relationships. But I think it's only us at this moment in time that's got that digital referral mechanism in place.
Yeah. I think, sorry, go on, Susan.
No, all I was going to say, it's very much a two-way thing as well, where kind of those contacts are there. And there's that kind of, it's got to come both ways kind of thing. It's not just about sort of like one person doing that contact. It's about that two-way, that partnership working, really.
Just to add to sort of, as Andy said, it's very, very early on in the journey, but obviously, you know, obviously having already really, really positive impact around sort of obviously those 30 referrals, but some conversations that we're already having, aren't we, Andy, in terms of how do we take it a little bit wider than just social, not just social prescribers. There's obviously various different health professionals that are going into properties, and it's just about trying to get housing on their radar and obviously the impact housing can have. So, you know, it's that back to that point that was made earlier about that making every contact count and how we roll this out. So health visitors, social workers, you know, there's so many others, community practitioners, and how do we sort of look at that in that wider realm across the Durham space, or particularly first of all living and then wider.
Saki, yeah, just to add to that, you're absolutely right, because I think that we've got this conversation not going with Susan and the social prescribers, but outside of that, you and I and Susan are part of a conversation, I think, with county, with NHS side of things. How do we look at the single point of contact? How do we bring in mental health support? How do we bring in carer support? All those, you know, leaving hospital side of things. It's quite difficult, and I think colleagues will probably appreciate that, and especially after the first presentation, there are so many things that are going on in the health world that from a housing perspective that we want to tap into, but how do we make it as easy as possible and more efficient as possible? And I think that's the conversation that's ongoing certainly around in County Durham at this moment in time to try and do that. Yeah,
because I think one of the main things, and I think you mentioned it out of that session that you held in October, November at Living Offices, was when, you know, I was going from one table to the other and everybody was just talking about, it's just about having a contact. It's just about having that one point of contact to make that referral into both ways, whether that's through housing or through health as well. And I think just coming away from that, just knowing that you've got a lead housing association contact in the room, and a lot of the social prescribers said, can I just take your name just as a starter, if nothing else, and follow up on those conversations. And I think that just, you know, meant a lot. And again, it just comes back down to we're all, you know, you go into a property and there's lots going on with a lot of these sort of tenants and residents and communities. Like I said, there's lots of complexity, and it's just about knowing where do you go with some of that if you can't help them with that. And if it is a housing issue, for instance, who do we need to, you know, make that referral to? Just picking up again a couple of other points from the chat. Do the County Durham social prescribers support children and young people, Susan?
Well, I was going to say Faith from Clearpath and the university has just kindly answered that to say that social prescribing is an over 18 service, but quite often those social prescribers will do that holistic approach around the family, and that often includes, there has been some youth social prescribers in County Durham, but they're now not around, so it's very much that over 18 service.
Yeah, as you said, it's that sort of whole family approach, isn't it? You're not just looking at that main person or that who's on the tenancy, for instance. It's what else is going on in that property, isn't it? And who else lives in that property as well. Yeah. Okay, brilliant. Any other questions, comments, reflections from anybody? Please do raise your hand, post in the chat. Okay, brilliant. Well, thank you so much again, Andy and Susan. Oh, sorry, just noted there. Rachel's just put, one integrated system for health, social and housing is the dream. The problem is contacts change, and keep a town-wide directory up to date is virtually impossible. Very true, Rachel. That is the case. And again, it's just about, like, you know, obviously Andy's just sort of said what living's done is about that digital sort of referral. Maybe, you know, that's one answer to that, because a lot of contacts do change. People come and go, as we know, in all walks of organisations, and it's about how do we make sure that our systems are proof of that where we you know, it still works regardless of who's come in and who's come out. Okay, thanks, Andy and Susan, once again. And obviously, again, if anybody's got any other questions or wants to take this outside of this webinar, please do feel free to contact them. They'll be on their contact details will be on the slides, which will be shared. But Andy, Susan, please feel free to post your emails in the chat if you wish to do so. Okay, Andy mentioned HACT. I mentioned HACT earlier on in my opening, and delighted to say that we have got Drew, Chief Exec from the HACT, joining us this morning to talk about, obviously, HACT do a lot of work in the health and housing space. They've supported a lot of our members, a lot of the health sector. We've worked with them over the years on an ongoing basis through various different forums and events around housing and health, and bringing that conversation together. Without further ado, I'm going to pass you over to Drew, who's going to talk about the work that they've done right across the HACT network around sort of unlocking the potential of social prescribing.
Thanks, Artie, and good morning, everyone. Hopefully you can see my presentation. Excellent. So as I said, I'm Andrew Van Dorn. I'm the Chief Executive of HACT. And as I've said, HACT and myself in particular, I've been working around this kind of housing and health space for some time, and also around the social value space. So, Andy, yes, I am going to cover some social value stuff and how you can use the social value method that we've developed around social prescribing. Also, I'm not just a Chief Executive of HACT, I'm also a non-exec director in the NHS, and I sit on the board of a mental health trust down in Hertfordshire, and have been a non-exec director in the NHS for about 10 years in a number of different roles, different trusts. So I kind of quite uniquely see the space of housing and health from different viewpoints. Kind of a bit of an interloper in some respects in the health world. Mostly my career has been in housing, in supported housing, and also in communities and community development as well. So really delighted to be here talking about social prescribing, which for me is a really core bit of that kind of community space that we are working in housing, and that I've worked in nearly throughout all of my career. I'm going to start, I think, by just coming up a little bit from to kind of, well, what is happening at the moment in the world of the NHS. I'm not going to spend a huge amount of time on this, but I wanted to kind of just put here the kind of Labour Health Mission. So we have a new government. There was a review undertaken and published before Christmas by Lord Darcy, and looked at kind of a bit of a stock take, a very quick stock take in some respects, about what's happening around the NHS and health in particular. And what the government then published was kind of its 3 key shifts. And this came out of the Darcy review. This is really what the government are now talking about. So they're talking about 3 really major shifts that they are expecting to see and drive through in their 10-year plan for the NHS. It's a shame that it's not a 10-year plan for health, because in some respects the NHS is just one part of how we drive health in our communities, and social care has a really important role to play, as does housing, as does many other things. In fact, only about 20% of our health outcomes is driven by clinical intervention. The other 80% comes from all those other things in our lives: our homes, our work, our community connections, our physical, our kind of the environment we live in. All of those things, actually, they have a much bigger contribution to health outcomes than the NHS does. So whilst I can't change that, and if I had Wes Streeting with me today, I would be counselling him to say, actually, we should have a 10-year plan for health, improving health in our society, not just the NHS. But these 3 key shifts are really important. So from hospital to community. And they talk about providing care closer to or in people's homes, helping to maintain independence. So there's a lot of language used around the home, and I'm not yet really convinced that the NHS actually sees housing enough. And it's really great that we've got kind of partnerships like we have up in North East and North Cumbria, but and in other parts of the country, but it's still early days in really hammering home that importance. So from treatment to prevention, so really thinking about how do we prevent folk from going into hospital, from actually having health conditions that worsen. And again, the role of social prescribing in that space is really important. And then from analog to digital, recognizing that actually there's still some way to go with regard to the digital infrastructure that the NHS delivers its services on. And actually there's also a key question for us within the social prescribing framework, which is how do we enable good connection through digital services, but also how do we make sure that there are good human connections as well, that actually digital can only take us so far, but actually we know that the actual one-to-one or even the group dynamic, the way that people meet, the way that people work together, live together, play together is an important part of how we drive health and health outcomes. So you're going to hear a lot about the Neighbourhood Health Service coming up. This is something that Wes Streeting, as the Secretary of State for Health, has put firmly on the map, and he's really challenging the kind of the local systems, the integrated care boards, the integrated care systems and providers, and primary care networks to really develop in the next year. It's a key part of the planning guidance for the NHS this year. And so we're going to hear a lot more about it. But what does it mean, I think, is an interesting one. And in some respects, there was some planning guidance that was published alongside a very large dump of documents on planning for the NHS just a couple of weeks ago. The planning guidance of the neighbourhood health service doesn't say a great deal. So in some respects, this is one of those places and one of those areas for us to create. And I quite like it when we get into those spaces that actually sometimes the NHS can be a little bit too top down and a little bit too centralising. So actually to kind of be a little bit more kind of humble, I think, in some respects about what does neighbourhood health mean, I think is important. And it means that we, as organisations working in communities, be they in health, be they in housing, be they in the voluntary community sector or elsewhere, we can create what this means for us in our communities, because it has to be, a neighbourhood is very different depending on which neighbourhoods you are in and where you are in the country. Even across the kind of the northeast and North Cumbria, you've got lots of different neighbourhoods, lots of different communities. You've got lots of different experiences of health inequalities, and you've got significant poverty and significant wealth in some of those communities. So they're not all equal, and we have to think about what does that mean for us. I think the key bit of this is that the focus seems to be on secondary prevention. And for folk in housing, we don't always have an understanding of what primary, secondary and tertiary prevention means. Often we just talk about prevention, but actually from a health and a public health perspective, actually there are some different concepts behind what that means. And for secondary prevention, that is actually about reducing the risk of more serious conditions. So that's where conditions have been already identified, and we are working in a way to prevent them from getting worse. And so primary prevention would be where we would actually try and stop them from occurring in the first place. So good quality housing, both general and specialist housing, is a really important part of how we promote health and well-being in the population. It isn't just a kind of wider determinant of health, as it's often framed. And I always slightly worry when we have this kind of language of the wider determinants of health, because it almost means these are other things that health shouldn't pay attention to. Whereas actually, I think this is a core bit of health. It's also about the organisations like housing associations who actually deliver much more in this space. And Sati talked earlier on around kind of the community investment work that goes on and has been going on for decades now. And I'll say a bit more about that. And then social prescribing, a really important part of this in ensuring that people are connected. Because what we know is that most people are not connected well into the range of support and services that exist in their neighbourhoods. And in some respects, social prescribing was an answer to that connection challenge, and an answer to enabling people to get to the right kinds of support and the right kinds of help and the right kind of community-based support that will help them improve their health. So what does housing bring in this space? So when I'm thinking about housing, I'm actually thinking about housing associations. And I think actually there's often an untapped potential and understanding around what housing associations bring. And there was a really interesting question earlier in the chat, which was, do other housing associations do this? And actually, just in some respects, yes, they do. But what we often find is that it's not all consistent. They don't do all the same things. There are a suite of things they all do, like provide housing management, tackle antisocial behaviour, deliver aids and adaptations. And there's other things that some of them do, and they do them in different combinations. So we know that, first of all, that good quality affordable housing is really critical. Actually, we have a homelessness crisis in our society at the moment. We have far too many families and children living in temporary accommodation. So actually accessing to good quality affordable housing is really important. What's worth noting that when we had the last time we had a big homelessness kind of consciousness in our society, which is in the 1960s, Kathy Come Home, the levels of homelessness are 3 times that than they were in the 1960s, particularly for families. Tenancy support is something that most housing associations provide to some degree, and a degree of homelessness prevention as well. So actually helping people to sustain the tenancies they have. They will all address issues of antisocial behaviour than they're required to within their communities. They will all have access to aids and adaptations, and will have programmes to enable people to be able to live successfully in their homes. Energy efficiency is a big issue for social housing. We know that there's a big kind of retrofit challenge. We know there's a big decarbonisation challenge. But also there is access to fuel support. And at HACT, we run a programme for all housing associations across the whole country who want to access fuel vouchers for their tenants. And we do that on behalf of the sector. And then finally, many housing associations provide some aspect of hardship support. Not all do this. It's usually the larger organisations, but not necessarily. And by hardship support, we kind of mean access to white goods, access to furniture recycling, and actually some direct payments to households who are in significant distress. But I think it's in community investment where we have some of the most exciting and vibrant work and opportunity when it's connected well into social prescribing. So this is about, and Zati mentioned earlier, the £750 million a year that housing associations in England spend on community investment, of which about 500 million is their own funds. So they do a lot of work around education, training and employment support, huge amounts of work in that space. It's probably the top area of their community investment work. The second biggest spend is around health and well-being. And that can be a whole range of different issues, from mental health, from health promotion, social prescribing services directly and indirectly. And there's kind of the work they do around financial inclusion and digital inclusion. So lots of this is kind of very anti-poverty based work, trying to, supporting people with those issues that they're dealing with because of the choices they are having to make because they're living on very, very low incomes. Often provide access to advice. Sometimes they provide advice themselves, or they work with other agencies in the community to provide advice. And then there's also a really strong area of work around kind of what we call safer and stronger communities. Now that could be around antisocial behaviour and crime. It could be around other aspects of how communities work together. And then finally, there's also the physical environment and the community assets. I mean, many housing associations actually have and manage community spaces, community centres. But they also have a concern around the local physical environment, and that could be around kind of how local parks and play spaces are. It could be just what's going on in the streets in which people live. And we know that when we address all of those issues, or any of those issues, it has an impact on people's well-being and people's health. If you're somebody, for example, living in a community with say early onset dementia, or even more advanced dementia, actually we know that there's a lot of issues that actually people are experiencing where housing association can play a role to be able to make that home and that neighbourhood much more able to help that person to get around and live their life successfully. But then there's also the care and support aspect of housing, and I don't want to lose sight of this because this is really important too. And this is kind of a key focus for some of the work that around the Housing and Health Partnership for the North East and North Cumbria. So housing associations provide a huge amount of specialist support to older people, in extra care, in kind of later living, sheltered housing, lots of mental health, learning disability and autistic people's support and housing. Domestic violence, you can see the list there. Lots and lots of different types of stuff, lots of supported housing that's provided in communities. It's worth noting that type of supported housing has been the funding for it has been reduced by about 80% in the last 15 years. So it's certainly not as vibrant as it used to be, but it's still a very big aspect of many organisations' work, many of their housing provision. And it's a really essential part of what they do as well. And actually, we mustn't forget that in there is also how do we enable access to not just social prescribing, but also how do we enable those who are going to social prescribers to be referred through to organisations and the support that's available to them. Going to say a little bit about social value now. And I think this is really quite important because in the work that we do in social value terms at HACT, we view this through a kind of a well-being lens. So what we're asking is what impact is made when when people's well-being improves. So that's our core measure. And what I've got in front of you here is just a few figures from an evaluation we did for Walsall Housing Group, looking at their social prescribing service. So many housing associations across the country, not a huge number, but some have actually been delivering social prescribing services for some time. And in fact, some of the early social prescribing services were first funded by housing associations. I think the earliest that we found is actually something that was happening about 10, 15 years ago down in Chichester. But there's work that's going on and still goes on today all over the country where housing associations are actually doing both the kind of the assessment and triage and referral, as well as the delivery of direct support. And the WHG evaluation, which we published in 2022, looked at what happened for the 277 people who were supported through their social prescribing service in Warsaw. Now, we had 187 cases that completed what was called the WEMWEB scale, so the Warwick Edinburgh Mental Wellbeing Scale, before and after the intervention. And the average kind of time in which people worked with their social prescriber was about 145 days. And we were able to show that there was significant change in mental wellbeing on that scale, and as a result, nearly £2 million of direct social value was delivered for those 187 people who showed that change. But there were also other outcomes. There were outcomes around employment, training, volunteering, and others that we also recorded. This gives you a little sense of kind of that change in well-being. So the yellow bar is the before intervention, and the teal bar is after intervention. And you can see that there was a significant change. Oh, sorry. So we know that social prescribing has a big impact when it's done well. And we know that actually from a perspective of the measurement that we use, which was the WEMWEB scale, we could see that change from before to after the intervention, a really significant change, which created that nearly £2 million worth of social value. But how do we maximise social value? And this is a really important question, I think, because what we often see is that even though it's a priority for all public bodies, so that's the NHS, that's local government, that's education, that's housing associations, all of those bodies is what we call public procuring authorities who can drive social value through procurement. What we often see is that they're not doing it in the same way. They don't even have a similar concept of what social value means. And I would also suggest that actually in some spaces, particularly in the NHS, it's a really unevolved space. It's not evolved much beyond what can we do around kind of environmental sustainability questions, or even maybe around it kind of employment questions, into a much more kind of holistic and exciting agenda around kind of population health and well-being. So if we can focus on social value and deliver that long-term transformational change, we can really unlock the full potential of social value. And that's the opportunity that we have. But we need to do that in a way which actually improves health and well-being and addresses those health inequalities. They need to be a part of this and of our core thinking, because also we need to base this on what is needed in each locality. And as we know, and as I said earlier, there is significant differences between different neighbourhoods and different localities across the area. But if we have clear outcomes and simple measures, we can all start to work in the same way, or not necessarily in the same way. We can work towards the same outcomes and be very creative in how we do that. And there are many different ways in which we can deliver a good health outcome, for example. So we don't have to do the same things. We can do very different things. But if we're focused on the outcome, it's important. But we also need to be focused on the evidence. And I think this has come up in the previous speakers, and it's really good that we've got some evidence, but we still need more evidence, because this is an emerging space, not just from a social value perspective, but actually from kind of a health economics perspective. So the more evidence we build, the better we are able to demonstrate the value that we have, and also the more choices we can start to make about what are the things we can do better that drive more value. And of course, procurement's a useful tool, but it's not the only tool, and it needs collaboration to do that, and then it needs delivery. If we locate the social value question just in a procurement challenge, actually we forget that at the end of the day, not one ounce of social value is delivered through procurement. It's actually all delivered by the work we do in communities. So we can do that, and we can base it on our wellbeing valuation approach with a range of different outcomes. Now, the next two slides talk a little bit about the outcomes. They're here because I know that Sarti is going to send these out to people afterwards. So I'm not expecting you to look at these in detail as I flick through them, but I do encourage you to have a look about what is there that you can use. So this is what the UK Social Value Bank looks at, a whole range of different outcomes that we can look at and we can measure in a really simple way that then attaches a social value to them. And you see there's health values there, it's the orange box, employment values, the teal box, you've got local environment values, improving energy efficiency in a home drives impact, working in the local environment, financial inclusion, and social hobbies and groups, and that's the grey box. So lots of different things that we can start to measure from a social value perspective that starts to build up a really compelling case of the outcomes that we deliver and the value of those outcomes to the individual and also to society as a whole. Final couple of thoughts for me. So first of all, the first one I want to focus on is this developing the ecosystem. I think we have to recognise that social prescribing outcomes are only built on the availability of local support. Social prescribing is a kind of a triage and referral mechanism. And it's really good to have those connectors in communities, because often people can't get to the things that they don't know are there, or they struggle to get to them. But if they're not there in the first place, then actually we start to undermine the whole social prescribing agenda. So actually we have to develop the ecosystem. We have to think really carefully about what is available. And we know that the poorest communities often lack investment in vital community infrastructure. We know that, for example, most national lottery grants don't go to the poorest communities in the country. So actually there's a lot of disadvantage that is built into the system in those communities that have the greatest levels of poverty. And we know that those areas with the greatest level of poverty are more likely to be social housing areas, and they're also more than likely to have really poor health outcomes. So we have to think carefully about how we build this. We have to address those inequalities, and we have to recognise that communities are under significant pressure. And actually, when people in the NHS and others say, "Oh, we're under real pressure," it's like, yes, you are, but actually the communities that you work in are under more pressure than you are. So we have to think about how do we extend our assets, our wealth, our value, and our infrastructure into those communities. So the other thing is that whilst there's considerable wealth in the NHS, that does need to be shared. And actually, small amounts of sharing from the NHS can have a big impact. If you think about how we spend that 160 billion pounds of NHS funding, I think it's even more than that now. The other thing is that social landlord support with investment in local communities is a really important bit. So how we can work together to kind of identify where the gaps and start to pump prime in some respects, those gaps, those service needs, those support needs in communities, and how do we co-produce those solutions? And being a bit of someone who has a career in housing communities and supported housing, also a bit of a community activist, I also know that really small amounts of resources can go a huge way and a really long way when put in the hands of very creative people in local communities. But all of this is going to require collaboration. So I kind of wanted to kind of end with a question about, well, how do we work together to do this? Because we know that we can't do this alone, and we know that actually there's a number of organisations, agencies and people, when we come together, we can have massive impact. So the first thing I'm going to say is that actually social prescribing is already taking place in communities. So ask, how are we already connected and how do we add value? That's a really important thing. So this isn't about creating new systems and new approaches. This is about building on what we already have, both from a kind of a assessment, triage, referral perspective, but also from a delivery perspective. Making every contact count has come up today, and I'm really pleased it has, because it's a really important principle where often what we do is that we put people are pushed, literally pushed around a system that makes no sense to them. And what happens is that often those with the greatest need fall through the gaps. So we have to think about, how do we bring support to people, not how do we make them fit into our system? And that requires a very different way of thinking, but actually that making every contact count is really important, because that duplication of effort is the thing that wears people down. And that's how they then start to disengage. Working strategically is really important. So we need to identify those strengths, those weaknesses, and those gaps, and work collaboratively to address them. And if we do that, we can lever in new resources. We can lever those resources in through our supply chains, as cures of the organisations we're working with, and we can lever in those resources from other areas as well. Really need to engage in this neighbourhood health service question. It is really up for grabs, I think. There's a lot of opportunity to be creative in that space and to make sure that we're wrapping around our people in communities all of the things that are really going to work for them, and working with them to co-produce that. But then let's put into place some very simple evaluation systems. Let's demonstrate our social value as we do this. Let's not end up in 3 or 4 years' time going, oh, we didn't really evaluate how we worked, because that would be a missed opportunity. And I think the final thing I'm going to leave you with is this idea of bring your whole self to this agenda. And I say this a lot to housing associations. Often they think that they interface with health through a community investment service or through the work they do in a specialist housing service. And I say, no, bring your whole self, because housing associations are doing a huge amount of work and have got a lot of work in the future in regenerating communities, decarbonising their homes, delivering that community investment. So let's bring our whole selves to that, and let's be the best anchor institutions that we can be, and let's work together as anchor institutions so that we have the greatest impact. And I'm just going to end it there.
Thank you so much, Drew. A lot to think about there. Really, really useful. Before I open it up, just a quick, I don't know whether it's a question or comment, but just in terms of the, when you're talking about the ecosystem and building that ecosystem, data, what's your view on that? Is that obviously we've heard a little bit about the data today and really where it takes us and how it really able to target our interventions. And there's lots of conversations in the Northeast, North Cumbria around data and how we really, really look at that, especially because we collect a lot of it in health, we collect a lot of it in housing, we're just not pulling it together.
Yes. What do I think about that? So that is a whole other webinar, Sati, I think. Let's be clear. So I think that where we get a bit stuck with data is that we get into the conversation that says we need to be able to match individual and household data together to be able to make a difference, to think about, to understand who needs our support and how to intervene. And in that space that's the most challenging space of all, because in that space we get into very, very difficult conversations around data, around information governance. And we start, and when we get into information governance questions, it becomes a little bit computer says no. So I would say we need to do that. And there is work actually going on at the moment in Liverpool, which is trying to do that, but working between a mental health and community trust and a housing association, Prima Group and Merseycare. But that's not all we can do. We can actually start to work at a more kind of neighborhood level with regards to the data that we own and the data that we have. And we can start to bring, and what data gives us is insight. Well, hopefully, sometimes data doesn't give us insight because data's too poor. Let's be honest about that too. But what we need to do with data is get to the point where we've got some actionable insights. So if we're thinking about, say, the neighborhood health service, what do we understand about the neighborhoods that we're working in? Because when we start to take things into a neighborhood level, we start to move a little bit further away from the more challenging information governance at the individual level to a bit more of a broad level where we can start to share data, we can start to share insight, we can start to use proprietary data that we hold in our organizations and match that to community-based data that is owned by government and published through the census and DWP and others. So I would say the data question is important, but we need to go where we can go first and then need to keep pushing where we'd like to go in the longer term.
Yeah. We did hold a data webinar actually as part of this series, the first one last month. And we did sort of explore that again, obviously at just sort of at the sort of very introductory level. There is some work being done at a very, very small place level. Carbon are leading on that with the data population team at the ICB, looking at just that bit about the warm and dry homes. So identifying those homes that potentially could be damp and mold or at risk of damp and mold and who lives in those.
And it's interesting because someone earlier talked about the work that was going on in Liverpool around healthy homes. And that piece of work actually goes back probably about maybe about 17 years. When it was and what they did about 17 years ago is that they pushed the HSSRS, the Health System Safety Rating System, Housing Health Safety Rating System, into the Joint Strategic Needs Assessment. And it demonstrated that if they wanted to have big impact, they needed to invest in the private rented sector and the conditions. So actually, sometimes, so this data space isn't necessarily new. It's something that's been going on for decades. But actually, what we have now is that we have much more data richness in some respects. We're much more data-driven businesses, and therefore we can do things differently, and we can start to chart a different course with data going forward.
Yeah, brilliant. Thanks for that. Any questions, comments, reflections for Andrew? Shunned them into silence, Drew. It's lots to think about, I think, to take away. And okay, just another final one from me then. Obviously, I know Hacked do lots and lots of work in this space. You've introduced, I know, definitely myself and the Northern House Consortium to lots of good practice right across the country. If there was one, or if there is one organisation or one area that's doing this really well in terms of that sort of building that ecosystem or starting to look at that, is there anyone that you're aware of that we might be able to take some learning from?
Yes, so I would look a little bit south to where you are. Go and have a look at what's happening in South Yorkshire. And maybe have a look at what's happening in West Yorkshire. So I think they're a little bit further advanced than West Yorkshire is a little bit further advanced than most around the kind of the housing and health integration. Black Country, really worth looking there as well. And South Yorkshire, because South Yorkshire Housing Association has been delivering a social prescribing service for some years now, there's a lot of learning about how that has been working and what needs to change. And there's appetite, I think, for it to change. Although what I would say is that I don't think anywhere feels they've really cracked it. And I don't think anyone will ever feel that they've cracked it. I think there's always a journey that we're on.
Yeah, brilliant. We've got some really positive comments in the chat. Obviously, Andy had mentioned earlier in his presentation that was something he was going to look at around social value. And I think it's reconfirmed following on from your presentation about that process to record those varying priorities. And then Rachel's just saying that, thanks, Andrew, I've taken a look at your slides and look forward to discussing these through the Darlington PCN network and linking it into our poverty proofing work as well. Okay, well, thank you so much again, Andrew. Really, really appreciate it. As I've said earlier, we will share the slides with everyone from all the speakers this morning. Thanks, Andrew, for sharing that as well. And you'll have contact details as well for all the speakers as well. As I mentioned again earlier on, this is obviously, we've heard some really, really sort of great work that's already been done and some sort of tips for us to think about and take forward and how we start to really, really make that change on the ground and really start to measure that social value to build up that evidence base. And I just really wanted to open up to the floor about anything really, anything either you've heard this morning, anything you haven't heard, anything that you're doing, anything you might want to hear more about, or you're exploring, anything at all really. It's just opening the floor for that wider conversation and discussion. Anybody brave enough to start? No?
I can add something.
Okay, brilliant. Thank you.
It's not anything major, but I don't know if everybody on the call knows that. So I'm from Carbon, I'm Innovation, and obviously we're looking at health and places. Sati well knows with the data, but I don't know if everybody on the call is aware that we have a befriending service, Silver Talk. So we use the Warwick Edinburgh scale for that, and that's completely region wide. So it's telephone befriending. So just to put it out there, obviously our colleagues in County Durham and some in Northumberland are familiar with it, but just so people know.
Brilliant. Thank you so much, Dan. Anybody else that wants to share anything or ask anything? Okay, then. Not a problem, but thank you so much for all of your time this morning and for all of your contributions so far. Thank you again to all of our speakers for some really, really insightful sort of discussion, information, just sort of putting it out there in terms of what already is going on, what's sort of next steps and what we really want to sort of start to think about. And as I said in the beginning, this is really a bit of a call to action about, there is some great work already out there. We're all doing some great work already. It's about really looking at that closely and where are the gaps, going back to obviously Drew's points just before about are we targeting it into the right places, are we measuring it in the way we need to be measuring it, and where are we building sort of that evidence base as well. Definitely. As I said, this is part of a series. We've got the next one in March. Details will follow shortly. That's sort of looking at, I mentioned as part of where this sort of program work sort of stem from, around our Housing Lin work around that baseline assessment. We'll revisit that. We'll bring Housing Lin to present some of those sort of key headlines and sort of about how we are, again, just going back to that sort of joint working, that collaboration, sort of bringing that to the fore as well, and getting some speakers to sort of talk about sort of what do we mean when we talk about collaboration and joint working, and what can we achieve by doing that as well. As I said, there's a feedback form that my colleague shared at the beginning. I'm hoping she'll just post it back again. Please do, if you get a chance, 30 seconds even of your time, just please do put some feedback forward, anything that we can improve on, anything you'd like, you didn't like, anything that we can do more of, anything you want to hear for future webinar sessions. And as I said, we will share the recording and the presentations with you. And for the Northern Housing Consortium members, you'll be able to access all of that through your My NHC portal. For anybody else, this will be uploaded on the YouTube recording, and then it'll be uploaded onto the Boost platform, which I think most of the sort of health and social care colleagues will be very much aware of as well. So thank you once again for all of your time, and enjoy the rest of your day. Thank you.